Welcome to the Heart of Healthcare podcast. I'm Hallie Tecco.
And I'm Steve Krause. And every Monday, we bring you the latest in healthcare innovation as we sit down with entrepreneurs and industry experts.
So buckle up and join us as we figure out how to improve healthcare for all.
Hello, listeners, and welcome back to the Heart of Healthcare podcast. I'm Steve Krause. Today, I'm talking to my good friend, Sean Duffy, the co-founder and CEO of Omada Health, a virtual-first care provider for pre-diabetes and obesity, diabetes, hypertension, and musculoskeletal disorders. Under Sean's leadership, Omada has been recognized as one of the Fast Company's 50 most innovative companies in the world and a technology pioneer by the World Economic Forum. Prior to Omada, Sean worked at both Google and IDEO, and is a former MD MBA candidate at Harvard, and he also holds a BS in neuroscience from Columbia University. So very impressive background. Sean, welcome to Heart of Healthcare.
Thank you, Steve. Happy to be on.
Yeah, so I want to talk about a lot of things today, but let's just first start about you. You take a quick look at your LinkedIn profile, and, it looks like a fairly traditional path to healthcare, science undergrad, business school, med school candidate. And if I talk to young Sean Duffy, when you were in high school or college, was your plan to be a doctor, an entrepreneur? Tell us about your path to where you are today.
It's funny. I kind of didn't know entrepreneurship was a path. I think actually until after college, at least in the way I conceptualize it now. I always loved tech generally. So I think in high school, played with computers. I was kind of a techie at heart. I think my claim to fame was I wore sweatpants through junior
so
year
did
of high school. Oh, good.
Yeah.
Okay. Yeah.
For other reasons, though, I was a little different shape.
I'll see you at the Dungeons and Dragons table. But in any case, I just love technology. But also like the idea of healthcare. It seemed like a neat way to have an impact and build a career. So it was one of those funny things. I graduated in 2006, and if you kind of bring your head back then, Silicon Valley was just absolutely on fire. It was just insane. It was like right when interactive web apps were hitting. And you didn't have to click on the corners of MapQuest. And I just was reading Slashdot, kind of yesterday's Hacker News, not cracking open my biochem book. And so I ended up getting a job at Google, even though I'd done my pre-recs, thinking I had to pick. And I think there I realized that just the power of entrepreneurship and just the power of creation and business creation and the impact it could have on society. And realize that, that actually could be applied in a neat way in healthcare and you could do kind of a tech plus healthcare, opportunity. And so that's when I went specifically to med school wanting to build some sort of business in tech meets healthcare.
Okay. So you did the MD MBA thinking you wanted the healthcare experience or at least medical background, but also with the MBA with the idea of being an entrepreneur.
Yeah, I kind of didn't know what. I thought, actually, I thought I would do something like a One Medical, like a very just super tech forward primary care practice. But just got the idea behind Omada or of Omada actually in that program. And rest is history.
Yeah, so I want to talk about Omada because, nowadays there's only one Omada, but there's 1,000 virtual care companies, right? And, back then you very much were a pioneer in this field. Tell the listeners, first of all, who don't know, I'm sure most do, what Omada does. And then I'd be more interested in where the idea came from, because it's a very different world, in 2006 or whatever than it is today.
Yeah, absolutely. So we're a between visit care provider. And so, and that I think is the best framing for the business. So we don't have as part of our care team, MDs, NPs, the folks that support our members are, diabetes educators, health coaches, LCSWs, physical therapists. And the core idea is, right now, if you're a primary care doc, oftentimes you'll send a patient with diabetes out the door with a pamphlet. Mm-hmm. You say, hey, come back in 6 months, and you're just wishing that there was something in that gap to support your patients, but there's nothing. And the reimbursement structures aren't supporting that. Your operational practices aren't supporting that. And that's really what's needed if you listen to a patient. And so, that's the opportunity that we saw. And so, and it was really against kind of a reality that, per your question, when we founded the business, there was very little that was trying to leverage the best of design and technology in a way that A, was evidence-based, B, looked at what practice guidelines existed relative to care, but work to leverage access and scale it digitally. And so we kind of ask, well, how might one build a more evidence-based digital health company? And then most importantly, well, what are the care areas where digital stood to, and digital care delivery stood to not just be incrementally better, but transformationally better thanks to the care model. And that led to the whole between visit thesis and really our start, which was pre-diabetes and weight.
Yeah. And I think I want to talk about all the parts of that design, protocols, outcomes, care model. But I think was the insight around originally the DPP, diabetes prevention program model, was that the insight? I know it's shifted since today, but like taking advantage of sort of that program, but making it digital, was that kind of the core instantiation of it, or was it even simpler than that?
Yeah, no, I mean, that was a critical insight, because it was like, well, the question becomes is what actually can be done? Like, is there any evidence at all that shows that any outcome that's meaningful can even be moved? And that evidence shows that something that's very clinically and economically meaningful can be achieved. I mean, it shows that it is possible. And so then it's like, well, that was done at a very high touch in-person setting. It was like, hey, Steve, come into my office once a week for a session. And that's just not practical. People are not going to prioritize that over their kids' soccer practice. So that did lead to the inspiration. And it recognizes that healthcare it tends to be a risk-averse buying market. And though, one might critique that approach as, isn't that just incremental? Like you're taking something that's been shown to be done and you're trying to scale it. No, that's actually like an amazing way for an entrepreneur to get started.
Yeah, I think you were thinking something that was like analog and turn it digital, essentially, right?
Precisely. Yeah, precisely. Yeah. And so that, and later on, I mean, now we're doing all sorts of crazy cool, like more de novo stuff. But that was a great way to get the company going, and, using kind of a reference trial that was well understood and allowed us to, learn from existing standard of care and kind of literature that existed.
Awesome. Okay, I want to take us back a little bit, because I said you're one of the OGs in our space, which is absolutely true. I think you started Omada in 2011. Is that correct?
That is right. Yeah, April 25th. We're almost coming up on our birthday here. Holy crap.
Oh, April 25th. Sorry. Wow. Yeah. 13 days away. Okay, cool.
Yeah.
Well, so can you describe to our listeners, some of whom probably haven't been in this space that long, what it was like to start a company in this space a decade ago?
That is very true. I mean, it was the early days of wearables. And I mean, in part, that was a little bit of the genesis.
Like Jawbone, we're talking, or like...
That's right. Yeah, Jawbone, Fitbits. Yeah. And it was funny, because I'd be with my tech friends, and there was a lot of enthusiasm, like, oh my gosh, these are going to change healthcare. Right. And then I'd be with my medical school classmates, and they're like, haha, Silicon Valley. Like, that's just cute. But really, the substance of their critique was like, well, what are the care areas? Like, where are you going to use this? What are the diseases? What outcomes are you trying to influence? Is there clinical value? Is there economic value? And so that's where we kind of saw the conversions opportunity. But it was very early. I mean, and I guess I didn't know that, because I was pretty green when I founded the business. I was 27. Oh, yeah. I'd never hired anybody. I didn't know what a VC was.
That's the least important thing.
So it was, and there were very few conversions VCs that did tech and healthcare. So it was quite different. The regulatory landscape was,
super undefined,
not at all evolved. I didn't know if we're not going to be regulated as a medical device. I probably burned. I mean, I raised a seed round back when seed rounds were $600K. I think I probably spent like $80K on FDA consultants, probably 20 of them, and they'd all give me different answers. So it was different. It was not mature.
What's changed? What if you were to take the big parts of the business? Like, what was probably the hardest part back then? And, where have you seen the most step function change in terms of our industry? Put aside maybe Omada, but just like as a founder in our industry, what was the hardest part back then? What do you think is different these days?
Well, I think everything's changed. Now the caveat is it's never like starting an enterprise healthcare business is never going to be easy. When tech founders come to me just for counsel and entering healthcare, I always tell them, like, look, it's double black diamond. Like, do it if you like care about the cause. Like, this is not enterprise healthcare. It's a complex place to start a business. You can build an amazing business that has an enormous impact in the world, but care about the problem.
Double black diamond. I love that.
I mean, it really is. I mean, do you agree?
I don't ski double black diamonds, but yes, I agree.
Yeah, but it's like, if you think about like, all right, so the three critical components relevant to your question, what's changed, has it evolved, easier, harder? It's like capital. Yep. You have more
Definitely
VCs that change. You have more VCs that get and understand both. Yesterday's pitches were, a little bit about like, all right, you'd go to the healthcare side. It's like, well, where is your monopolistic IP? Yep. You go to the tech side. It's like, why are you putting $1 million into a clinical trial?
Yep.
So it's that doesn't exist.
Right. It's like, why can't you hyperscale payers? Because you can't.
Totally. Yes, exactly right. Exactly right. It's like, yeah, for sure. So I think the capital landscape is more mature. So that's one, right? Well, what is capital? What is it used for? Well, you need talent, right? To build anything that, so, and then talent landscape's more mature. You have companies like Omada that have shed talent that has lived a world where you need to innovate in a regulated environment and have sold innovative products into existing landscapes. So it's like the talent market is just better for convergence companies. And then perhaps most importantly, the buyer's better.
Can I ask you a question on the talent for a second? Do you think that's, and I'm going to make a generalization here. I know nothing's black or white, but do you think the healthcare talent's gotten more tech or the tech talent's gotten more healthcare?
I think both. I mean, that's the easy answer. What would be, I think both. I think you have a little, I think it's harder to go tech to healthcare. As much as I might get harassed by one camp versus the other by saying that, but it's the learning curve to enter healthcare is just so extraordinarily steep. It is absolutely remarkable. So, but that being said, I mean, you can do it.
Yeah.
You can absolutely do it.
So, the learning curve's probably coming. Yeah, it's definitely steep. But I also just find like the patience you need to have. It's like it's just a little. It's a little bit different of a RPM cycle. Which
sure.
I would, if I were in a tech person, I think might be challenging.
Yeah, but you can do both.
And then, sorry, I cut you off. So talent, and the third was going to be
just the buyer maturity. Like I think buyers better like know how to buy like digital offerings, and I think there's just early on. This happens far less now, but early on, Omada's a covered entity. You'd kind of go to either an employer or a plan, and they'd be like, well, where are your offices? Where are the clinics? Yeah. The buyer market is just far more evolved, which is very important for entrepreneurs. Like buyers need to know how to buy and have the internal processes to do it.
Yeah, so. I'd love to talk about GLP-1s and how they affect your business, both Omada specifically, but I know you're a huge believer in wanting to change healthcare, how they're going to change the healthcare industry. So.
Yeah. I mean, for starters, I think they're really amazing medicines. I mean, they were a breakthrough. Like society invented these, and that's just like a remarkable accomplishment. They're like anything. There tends to not be a silver bullet. So the classical challenge you'll hear and the classical critique you'll hear about GLP-1s is the cost. That's kind of the obvious. I mean, they're enormously expensive medicines at current price. And then,
but presumably that's going to change, right? I mean, over time, that price will come down the cost curve, I presume.
Yeah, I mean, one would hope. Now, the counter argument to that would be like there's exceptional R&D innovation in the next category of incretin, right? You've got like the triple agonists and the ones with like, so who knows where that class of like incretins goes from a therapeutic standpoint. But so net, they're expensive. That's kind of current state. My belief on how we can contribute and how I think about them is I think GLP-1s they're really phenomenal at quantity. They help you eat fewer calories, but they alone, they don't get to know you. They don't teach you a new recipe. Like they don't say, hey, Steve, what physical activity do you like to do, don't like to do? Anything you want to dial up, dial down. So they don't do anything about quality. So in theory, one could eat a very poor diet and lose weight on a GLP very successfully, but that's not the best for your overall nutritional health. Nor if at some point you choose to, Omada leaves it in the patient choice to kind of decide whether or not you'd like to or not try to discontinue. But if you choose to, if you do say, hey, I want to actually see if I can get off this med, the likelihood of success is far higher if you've done work on the quality side.
It's like make it a behavior change rather than a Band-Aid.
That's right. So that's kind of our belief system, and I mean we've lived in this in this pre-diabetes weight space for, I mean, that's been the core of what we've done for over a decade. Our approach is behaviorally based. It's not it's kind of listening to someone's goals, trying to map kind of a diet approach to what's feasible and practical and will work for them, ideally sustainably. So we think we're pretty well suited to this. And so we launched, about 2 years ago, our GLP-1 care track. Okay. I'm just so excited about that. I want this to be like just a societal contribution.
We'll be back after the break. Tell me a little bit more. How does that work? I mean, because I know you pre GLP-1s more, but how does Omada work with the GLP-1s in your care track?
Yeah, so it's a layer alongside a GLP. So if you're on a GLP, so Omada doesn't initiate folks on the medicine, but rather operates alongside. So an employer can say, hey, look, if I'm going to pay for a GLP, I kind of would ask you to do Omada alongside. Okay. But not framed as punitive, framed as like, look, in addition to covering your GLP-1 for obesity, I'm also covering, a world-class companion program. And then there's all these aspects, the whole therapeutic life cycle that we've got these capabilities. I mean, we've kind of already introduced like full care team training, these resources, like community layers, but there's all these subsegments of personalization on if you're responding, how to support you with side effects. And so there's this whole layer of like innovation that you can foster on therapy. And then again, if you say, hey, look, my goal is to seek to discontinue, nobody's having the honest conversation, as I see it, relative to how hard that is and what a headwind that's going to be.
Meaning how hard it is if you want to discontinue and try to maintain your weight and not have a rebound effect. Is that kind of? Yeah.
That's right. So exactly. So, but I mean, it's a doable thing. You just need to start having that conversation up front.
Yep.
And say, hey, Steve, wonderful. Let's work together, like to build some sustainability in the habits here. And then there's this whole like post-discontinuation work you need to do to try to increase basal metabolic rate, like increase muscle mass. Like there's a lot of sophisticated work that needs to happen.
Do you guys have enough longitudinal data yet to know for the folks who are on the Omada Care Track plus GLP-1s that choose to discontinue what you've seen in terms of outcomes? I'm curious.
We're getting there. We announced data that demonstrates that the highly engaged with Omada have about 1.7x the weight loss outcomes while on therapy, which is really neat. Well, and that's kind of part of the value prop to the account. So we don't view it as our job to try to convince an employer or not to cover GLPs or not, because they're quite expensive. So, but it's like, look, if you are covering them for obesity, we think our job is to help maximize the value of that decision. So, so what does that mean? That means, like, let's operate alongside and serve your employees well on the quality side, because that'll, likely lead to, hopefully lead to, better, deepened results, and then, more chance for durability.
Do any of your employers look at you as sort of I'm going to say prior auth, meaning that in order to initiate a GLP-1, you need to use Omada first. And then Omada could be used with metformin. Omada could be used with a GLP-1. Omada could be used alone. Do you see that as a place that you guys could play? I know you wouldn't use the prior auth language, but you probably get what I mean, to sort of manage the sort of lifestyle of a patient that you work with.
That conversation happens. I will say it's the exception rather than the rule.
Okay.
The more common is what I described, where it operates alongside as a requirement. Because the use Omada first, and then if you unpack it, it can create kind of some funky like psychology. It's like you don't want someone kind of thinking, oh, well, what is this? Like, how long do I have to like fail this to get my GLP-1 script? It's like, and the buyers realize it's just, so it's funny. I thought it would come up more than it has, frankly. So who knows? I mean, maybe that'll start to appear more in the market.
And you don't need to names, but what percent of employers today and payers today are covering GLP-1s versus not, that you run into? And
what we see is pretty close to what you'll see in like the Mercer and the Towers reports, which is like 30 to 40% we'll cover for obesity.
Got it. And what's your view long-term on these things? I mean, do you think they existentially change human healthcare?
I mean, I think they're again, I think they're a remarkable tool in the toolkit. I think they will always need and should have a services layer on top for all sorts of reasons. I mean, the big worry right now, which I think is an appropriate worry, is like if you lose weight on these and just stop and regain, what's likely to happen is you're going to lose lean mass too, and then you're likely to regain only fat. Yeah. So that's a huge problem. I mean, you've actually you're kind of worse
structurally.
Off. So
Yeah,
structurally. I mean, we don't could have tomorrow's clinical story to be just an epidemic of sarcopenia. So, I think they're amazing. There's incredible innovation. We're lucky that these were invented at a moment in time that they're really dearly needed. I just think they need to be complemented with the quality side.
Right. We're taping this in, early April, and this report, this controversial report called the Peterson report, came out.
Oh, sure. Yeah.
And I know I talking to you at a conference. You have some strong opinions about it. I'm curious. This is a report that sponsored by a nonprofit institute, and showed that a lot of the diabetes management programs aren't efficacious according to their methodology. I'm curious how your view when you first saw that Peterson was doing a report and then you saw the results. How do you process it as a player in the industry, and how do you process as someone who I know cares deeply about kind of moving outcomes forward? Like, what was your take?
I think at the end of the day, it's like I think it's both a statement on the maturity of the space, that it's being done at all, but also a little bit of the immaturity of the space. And so, the puzzling thing to me, there's the outcomes which I'll talk about, but it's like literally there are 2,000 DSMES sites, according to the CDC, that are providing diabetes self-management education across the country right now. Like Omada is an NCQA accredited DSMES provider. So it's like, is that a technology? Like maybe, just because we deliver it digitally. Like, I guess. So it's funny. What it shows is like, how do we think about how companies like Omada are evaluated?
By the way, I agree with you. Put the results aside. I agree with you that it's a reflection of how far our industry's come that we actually have this now. When you say the immaturity, is it because we don't really know how to catch? I said on the podcast with Hallie when we talked about this, like if you measured the as a system, they would fail this report too, writ large, right? Most healthcare provision. So is your point about immaturity is that we don't really know how to advocate for ourselves as an industry, digital health, how to classify ourselves? It's
a little bit of both. It's like, all right, well, if the intent is to serve as some sort of like a quality measure, or like, does this work? Does it uphold to like quality standards, value standards? Usually that intends to fill a void. So specific to diabetes, the first thing we did is look at Omada. As we approach diabetes, we didn't start in diabetes. We started in, pre-diabetes and weight. We're like, well, what exists out there? We're like, great, there's a whole quality framework. Let's be the first to lean into it.
Right, we talked about it.
We became the first and only to become NCQA accredited in diabetes self-management education support. And then we're like, well, should we run trials? We're like, let's do it anyway.
Yeah.
So and this was a little bit of a timing thing finally with that one. We ironically like released our year-long results, which are really compelling diabetes results, like the week that came out.
Yeah, you just said you're having RCT. By the way, it also says the immaturity. I was going to ask you, it takes a long time to run RCT. First of all, kudos to you for running it, but how long does that take actually to do a true RCT?
Forever.
Right.
Yeah, really long. And Omada started in diabetes in about 2019, and then we started the RCT. I don't remember when that one kicked off, but it's years. It's many years. So and then it's and if you look at the companies on that space, I think those are all innovators trying to just innovate in diabetes care, trying to do the right thing. And they're all very different. So it's like the thing that I've been approached with most commonly is like, how funny, because like you are so different than Gluco. And I'm not like trying to critique Gluco in any way. Like that's a great company. But it's like, that's like that's like so night and day different. Yeah. Like anyone who's ever studied the space, you would be so puzzled that you would even consider those to be anywhere near each other on the same page. So again, to my original point, I think that there's value in working to help, elevate the quality bar. We've kind of done our own way of doing that, trying to lean into existing quality frameworks and publishing our own literature. Sure. Yeah, so I guess it's good net to have other voices in the space, and we'll continue to do what we do.
Yeah, I also think it's, as I said, it's a point in time. So my hope is that they do this year after year after year, and 10 years from now, Omada will be, will perform much better, I'm sure, than it did today, just because of the maturity of Omada, and the industry will mature, right? And so I'm curious, I know you've got lots of goodness coming ahead for you guys. The digital health markets are pretty grim right now. And, you and I are believers that they're going to turn around. What do you think turns around I'm talking about from a public markets and an investor's perspective on digital health right now?
I think the sun's coming up over the horizon. It's funny. I think it's been a little bit gloomy. I think to be honest, I think it's no secret. I think we got a little over our skis during COVID.
Yeah, for sure. People thought that was signal, and it was a little bit of there was some signal, but there was some noise there too.
Yeah, it was funny. I remember during COVID, the number one thing I kept thinking about and almost trying to remind the world is guys, in-person care is still important here. It's
people are going to go back to the doctor eventually.
Yeah, moles need to be removed. You know what I mean? I wrote this piece in partnership with Chrissy Farr. I looked at all the CPT codes and tried to judge them on could or couldn't be done in person. So a piece of it was just the pendulum swung a little bit too far, and then I think it swung a little bit too far to the left, and it'll end up in the middle. I also think there's within that, clarity of value prop is just really important. And that, and that's what I've always loved and appreciated about Omada. And I think that there's a whole class of companies that's the same. It's Omada, here are the condition areas where we support care. Our pricing model is such that when we help someone, we charge.
Right.
And that's that.
Right. Right. And by the way, you charge something that works for your unit economics and also works to make an ROI for your buyer.
Yeah, precisely. Yeah. If someone stops using it, we stop charging. We have performance guarantees on HEDIS measures. It's no PEPM, no PMPM. It's all incentives are aligned, and it's just a crystal clear value prop. And there's a lot of clinical data. We have 28 trials coming. We mentioned the RCT, we've got invested in research, the whole GLP landscape, really cool capabilities there. So I actually think that the assets that exist right now in Omada's category and kind of the next generation of companies are just really cool.
I agree with that, by the way. If you do it the right way, you can build really sustaining companies that, like any company, you put it really well. Your product works. You're able to price for it in a way that you make money and your customers make money. And by the way, the greatest thing about what we get to do is, we get to change human health outcomes.
Oh, totally.
Totally. And the TAMs are very large.
No, for sure. And you know what these the tougher moments in the capital landscape do for companies? You really not that you shouldn't do this anyway. And, Omada's always worked to really, really make sure that everything's hanging together. But it's you really just really focus the business.
Clarity.
And and then you end up with better businesses. So I actually don't think you ask kind of what needs to be done. I don't think anything needs to be done. I think we're on a course that where enthusiasm is already starting to return and will naturally return just based on the quality of the companies that exist right now that are, heading to the next chapters.
The second cohort of IPO companies will be more mature, and frankly, the business models will be better understood, and that should lead to.
There's some just great companies out there right now. So
well, okay, I think anybody listening to this podcast can first of all tell that you are so experienced in this space, and also anybody who knows you just knows that you're one of the absolute great guys in the industry. I don't know anybody who says a bad word about Sean Duffy and just wants to be massively successful. So with that said, your advice is pristine, I got to say, and people should listen to it. What would be the one piece of advice to end the podcast that you would offer to digital health founders?
Oh man. I think I think I teased on this. It's I think if you're building in enterprise healthcare, make sure you really, really find the problem that pulls you. And that pull, make sure you identify it not as an economic pull. So the reason being, and this kind of speaks to the commentary relative to tech friends that come to me. If I ask them why they're interested in healthcare, and they say, because it's 20% of the GDP, I'm wrong answer. It's because it is a hard business to build. So there has to be something that you almost feel like it's an injustice that it works that way. It doesn't matter what that is, but that's kind of what you need, because at the end of the day, grit and determination is what's required for any entrepreneurial endeavor. Yes, of course, you need all the other things too. But I think if you pull successful founders and leadership teams and ask what really got you through. It's like, we didn't give up and it was the grit. I think that's probably the cardinal truth. And then kind of the second question to that is, what gives you the grit? It's actually like the problem itself and your identification with the problem. And that's what I love about Omada. The beautiful thing is, like, I abstract myself away from the business and I ask, should somebody swing at this and swing at it hard? The obvious answer is yes. So it's like, it's great. And like, well, why, it may as well be me. So so that I think is the guidance. Make sure you really find that problem that pulls you,
Totally agree.
because that's what will make the outcome that much more likely to be successful.
Yeah. It's a double black diamond. You got to want to be able to get up a bunch of times.
Got to put on those skis.
Yeah. All right, my friend. Well, this is super fun. Just a great, honestly, overview of digital health history and in particular Omada and yours as an entrepreneur. So I really appreciate you coming on and sharing your story.
My pleasure, Steve. Always fun to connect.
Thanks for listening to The Heart of Healthcare. If you enjoyed this episode and you'd like to support the podcast, please leave a rating and review, and don't forget to subscribe. The Heart of Healthcare is produced by Hallie Tecco and Steve Krause. The show is engineered, edited, and mixed by Kyle Moore. Visit our website, heartofhealthcarepodcast.com, for show notes and episode details.